Hi guys, our group gonna talk about schizophrenia in this video. Schizophrenia is one of the most severe, complex, and debilitating of all mental health disorders. It is a progressive disorder with no cure but can be treated. Schizophrenia is a lifelong disorder characterized by periods of psychosis. Now, let's talk about etiology. Schizophrenia is not caused by one single factor. Research supports both genetic and the environment can be the triggers that cause schizophrenia. Dopamine, glutamate, and serotonin play the role of the key neurotransmitters while are being explored to determine their role in genetic alterations. Several findings on neuropsychological and brain imaging reports that the presence of genetic markers reduced brain activity in frontal and temporal regions and structural abnormalities in all regions of the brain, including enlarged ventricles, reduced volume of gray matter in the cerebral cortex, and decreased size of hippocampus and thalamus. Perinatal development complications or delivery periods can affect brain development that has found associated with schizophrenia. Furthermore, complications in later brain development, including chronic cannabis use, exposed to trauma, or other stress also correlated to schizophrenia. The cause of schizophrenia still remains a mystery. Despite various research on it, there is a hope to find the causes that can ultimately lead to prevention and treatment in the future. The incidence of schizophrenia is low compared to other mental illness. The median rate is about 15.2 per 100,000 people, and the lifetime prevalence is 4 per 1,000 people. Schizophrenia has no difference for all racial, geographical, and socioeconomic boundaries. Some studies indicate that low socioeconomic status, living in a higher latitude, and males have a higher incidence and prevalence to get schizophrenia. Here are some key terms of vocabularies we will talk about in the further slides. They are alagia, anhedonia, asociality, evolution, catatonic behavior, delusion, disorganized behavior, dysphoria, extrapyramidal syndrome, hallucinations, paranoid, and tardive dyskinesia.
Core symptoms of schizophrenia fall under 5 main categories. These are delusions, hallucinations, disorganized thinking and/or speech, grossly diagnosed or abnormal motor behaviors, and negative symptoms. Delusions are defined as when a person holds a belief despite what real evidence may be contradicting to it. The person often cannot tell what is real versus what they are imagining. There are 6 common types of delusions that we will go over. The first and most common is persecutory. This is when the person feels that they are being watched or victimized. Paranoia is a common form of this, and often the person believes that someone is trying to poison them, so they refuse to eat or drink. The next type is referential. This is when the person thinks that common cues from the environment, such as people's facial expressions or overheard conversations, are directed at them specifically. Then there is somatic. This is involving a belief about their body, like that someone has secretly planted something in them during an operation. Next, there are religious delusions. An example of this would be if someone thinks that they are Jesus Christ or obeying direct orders from God. Next, there are grandiose delusions. These are characterized by believing that they are all-powerful or much more important than they actually are. Finally, there are erotomania delusions. This is when the person believes that someone, whom they typically do not know, is in love with them. Hallucinations are when the person starts to experience sensations that are not actually real to others around them. The most common is auditory, in which the person can hear voices speaking. Sometimes the voices may be speaking to each other, and other times speaking directly to the person. Oftentimes they can be demanding voices and can be rude or cruel to the person. The person may feel like they can see people that others cannot. Less common hallucinations are olfactory, tactile, and gustatory. Disorganized thinking is often characterized by the person's speech. This gives further clues as to what is going on inside their minds. This first type is loose associations. This is when the person's answers really start to go off track from the original question. This is not a slow progression to another topic, but rather more quick jumps, sentence after sentence, to a new topic. The next type of speech that gives clues is tangential speech. This is when the person provides unrelated comments to the conversation. Lastly, there is incoherent speech, also known as word salad. The image on the left gives an example of what it may be like, but in general, a person will link words or phrases together that do not make much sense. Grossly disorganized behavior affects the person's ability to participate in daily activities. This may consist of angry outbursts or masturbating in public. They may also experience catatonia, which is described as abnormal motor behavior and having a loss of environmental cues. They may appear rigid and unwilling to allow someone to readjust their posture. The last of the 5 core symptoms are negative symptoms. These can be thought of the person lacking something. This may include decreased emotional expression in their facial expressions, eye contact, or speech. They could also experience avolition, alogia, anhedonia, and asociality. Out of all of these, the 2 most prominent features are avolition and decreased emotional expression. More symptoms that are not included in the core symptoms of schizophrenia include cognitive and affective symptoms. Cognitive symptoms are characterized by deficits in memory, language, attention, and executive functioning. This makes it hard for these patients to plan and think abstractly. These patients also have a hard time responding to visual and environmental stimuli. Their social interactions are usually affected, as they have a harder time picking up on social cues and what is socially appropriate. Their mean IQ scores have been found to be around 80 to 85, which is lower than the general populations of about 100. Lastly, we have affective symptoms. Patients often have a flattened affect, which is a severe reduction in emotional expression. As you can see on the right, the woman pictured shows the same blank expression for each emotion that she is feeling. People with schizophrenia also have issues recognizing facial expressions. This affects their ability to appropriately interact in social situations. These patients also experience mood disturbances such as dysphoria, depression, anxiousness, and anger during or following a psychotic episode. Starting off the course of this diagnosis is premorbid functioning. This often reveals subtle signs and problems that may be arising. This may be motor development, affect, or cognitive issues in school. The prodromal phase can last from weeks to months to years before the full-blown signs of schizophrenia take over. This consists of unusual behavior and signs of psychosis. More intense symptoms during the end of the prodromal phase may include suspiciousness, brief hallucinations, and perceptual difficulties. The course can vary greatly between individuals. It can be classified as a first, multiple, or continuous, and during either an acute episode or partial to full remission. Noncompliance with medication and continuing substance abuse may increase the individual's chance for relapsing. Factors that may negatively impact prognosis include being a male, early onset of symptoms, family history of the disorder, experience of abuse or neglect, negative family relationships, and poor premorbid functioning. On average, people diagnosed with schizophrenia die about 12 to 25 years earlier compared to those of the general population. The DSM-5 states that to be diagnosed with schizophrenia, the person must have 2 or more core symptoms for at least 1 month and clinical signs present for at least 6 months. It is also required that one of the 2 core symptoms must be either hallucinations, delusions, or disorganized speech. The typical age for diagnosis is between 16 to 30 years old, and males are usually on the earlier end of this range. Children can also be diagnosed before the age of 13, also known as childhood onset. Early pharmacological treatments consisted of antipsychotics that were developed in the 1950s, used to treat positive symptoms. Unfortunately, these had severe side effects that caused severe motor impairments. In the 1980s, atypical antipsychotics were introduced that targeted different neurotransmitters in hopes to avoid the severe side effects. These medications do not cause as many motor impairments. However, patients still face side effects such as restlessness, dry mouth, and blurred vision. Another treatment to manage schizophrenia is known as transcranial magnetic stimulation, or TMS for short. This is still being studied, and although recent studies have been inconclusive, researchers feel that it shows great promise in reducing the negative symptoms that many medications cannot treat. TMS uses a magnetic field on the brain to change brain activity in areas that cause psychotic symptoms. Finally, electroconvulsive therapy, also known as ECT, can be used to treat more severe symptoms. Patients are administered anesthesia before the procedure, and then a seizure is induced by sending an electrical shock through the patient's brain.
We will now discuss how schizophrenia impacts occupational performance. Though schizophrenia affects a variety of occupations, this presentation will focus on education, leisure and social participation, work, BADLs, and IADLs. These occupations were selected as they are often priorities at the start of adulthood, which is when the onset of the disorder usually occurs. As noted earlier, changes in cognition during the premorbid functioning stage may impact academic performance. Specifically, formal education participation will become difficult due to deficits in memory and attention, impaired speech, and inappropriate social behavior. Because of symptoms, test scores and IQ scores may decrease, and as the course of the disorder progresses, plans to graduate high school or complete post-secondary education will likely be canceled if symptoms are left untreated. Schizophrenia also impacts the occupation areas of leisure and social participation. Anhedonia, lack of motivation, and limited resources such as money and transportation decrease participation. A study by Huang and colleagues found that decreased cognitive abilities such as attention and orientation inhibit the achievement of flow state for individuals with schizophrenia while doing leisure activities. For anyone that needs a refresher on flow state, it is described in the article as having clear goals and total control, forgetting about your surroundings, and experiencing pleasant emotions while engaging in an activity. This article provides further evidence that individuals with this disorder may not participate in leisure because it may not be perceived as fulfilling or enjoyable. Social participation is also impaired by schizophrenia. Symptoms such as inappropriate behavior, inability to respond to cues, and limited opportunities for interaction decrease participation. Additionally, the stigma attached to schizophrenia may hinder social engagement. Because individuals with active schizophrenia typically complete lower levels of education and lack social participation skills, acquiring a job can be difficult. Problems attending to the pace of the work environment and processing information decrease job performance. An individual with schizophrenia has greater potential for success in a work environment that is flexible with work hours and task completion rates. A number of BADLs are impacted by this disorder. The ability to bathe and complete hygiene routines is limited by changes in cognition, abilities to process visual stimuli, and motor skills. For example, an individual may over-apply makeup without realizing it or unintentionally miss a spot shaving. Maintaining general health,
by receiving adequate nutrition and exercise is also impacted by symptoms. Cognitive, sensory motor, and social skills are required for a majority of IADLs. Because active schizophrenia limits such skills, engaging in home management, meal prep and cleanup, financial management, and the care of others is often difficult.
The Executive Function Performance Test assesses cognition and executive functioning. IADL tasks include cooking, telephone use, medication management, and bill paying. The EFPT serves three purposes. 1. Determines deficits in executive components such as initiation, organization, sequencing, judgment and safety, and completion. 2. Determines capacity for independent functioning. And 3. Determines the type of assistance necessary for task completion. The performance assessment of self-care skills is an observation tool that examines the person, task, and environment. ADLs and IADLs performed are assessed using a 4-point scale to measure independence, adequacy, and safety. Cognitive areas of IADLs include shopping, paying bills, communication management, obtaining information, home safety, cooking, and using sharp utensils. The Coleman Evaluation of Living Skills is an observation and intervention tool that can be used to assess living skills in patients with mental health conditions. Areas of assessment include ADLs, cognition, communication, life participation, and occupational performance. The 5 testing areas include self-care, safety, and health, money management, community mobility, and phone use, employment, and leisure participation. The COPM can be administered to gain an understanding of importance, performance, and satisfaction areas from the client's perspective. Treatment for individuals with schizophrenia include cognitive approaches, social skills training, peer support programs, community arts, ADL and IADL training, permanent supportive housing, sensory processing, supported employment, and supported education. Some cognitive approaches include cognitive remediation and cognitive adaptation, as well as the cognitive disability model. Cognitive remediation aims at improving attention skills, memory, and executive functioning through graded and repeated practice of cognitive tasks within the context of occupational performance. For example, there is evidence for improving executive functioning in individuals with schizophrenia through attention training. Cognitive adaptation is designed to adapt the environment or task to compensate for cognitive impairments. Cognitive adaptation training provides strategies for individuals with no interest or concern which focus on prompts, cues, checklists, and placing everyday objects such as a toothbrush within eyesight. Individuals with schizophrenia can benefit from compensatory thinking techniques such as self-talk. For example, a therapist demonstrates a self-talk process, then asks the client to talk themselves through the task, such as leaving the house in the morning. This helps individuals attend to the task, think through the steps before acting on them, and supports development of automatic processing through repeated practice. Cognitive disability process model has also been shown to be an effective intervention approach for social competence and community living for individuals with schizophrenia. Social skills training aims at developing communication and interaction skills. Individuals with schizophrenia may show social incompetence, experience social rejection, lack of motivation, and low energy, as well as the inability to find pleasure participating in social interaction. Peer support programs target social connectedness and support. These groups provide education, socialization, and advocacy. Additionally, they are typically led by individuals who have experienced mental illness. Community arts uses creative media to promote well-being and socialization by increasing self-esteem, confidence, and social networks. It provides those who are socially isolated with a valued identity. ADL and IADL training involves using learned skills and behavioral strategies to promote acquisition of new skills. OTs can assist with permanent supportive housing by helping the client form interpersonal relationships with the landlord and other tenants, engage in routines and lifestyle practices to sustain cleanliness inside the house, engage in leisure and social activities that are not disruptive to neighbors, yet satisfying, and develop a sense of home. Sensory rooms that create a calming environment within treatment settings are helpful for individuals when they're feeling angry, agitated, or anxious. Auditory and visual senses should be considered, as individuals with schizophrenia have most difficulty with auditory and visual processing. Through supported employment, OTs assist the individual with attaining a job in competitive community-based employment with ongoing supports. Supported education targets goals related to higher education by providing individualized practical support to succeed.
Occupational therapists are part of interprofessional team within community and inpatient mental health services. Nevertheless, OT can also work to promote mental health and facilitate recovery in other areas, such as primary care, higher education institutions, secure settings, and prison. Occupational therapy service promotes equal access for mental health service users with physical disabilities. These include the development of action plan, disability equality scheme, as known as DES. Several studies has found a significant improvement in the goal setting and the quality of life of housing transition program for homeless shelter residents with chronic mental health problems and substance abuse. The authors suggest that there is a role for occupational therapists in working with homeless people with mental health background is to establish the role. Occupational therapists support participation in daily activities through engagement in occupations that are meaningful to the individual. Occupational therapists are trained to deliver therapy on improving occupational function and participation based on the needs of the client. Occupational therapists can also offer a valuable perspective towards health promotion for healthy lifestyles and facilitate participation in meaningful activities. The purpose of occupational therapy is to promote good mental health and assist recovery to help people achieve their personal outcomes, such as being able to care for themselves, engage in work and leisure activities, and participate with community events. Occupational therapists help people with severe mental illness to regain feeling of competence, meaning, purpose, productivity, and social cohesion. This aims to help individuals to reconnect with their roles, achieve their goals, and develop feeling of self-efficacy, belonging, and promote well-being. Engaging in employment has been identified as a major concern of mental health recovery. Providing opportunities with appropriate support is critical to help clients overcome barriers.
Assistive technology can be used for patients with schizophrenia to better engage in their occupations. Recording devices may be useful in classes or at work so that the patient can go back and listen to what the lesson or what the job description was for that day. An iPod or iPhone would allow the patient to have downloaded music to listen to in order to help block out auditory hallucinations. Mobile applications can be downloaded onto the patient's smartphone as well. NAMI Air is an application that allows patients to connect and find support together. Medication applications can be downloaded as well to help the client stay on a schedule and give them reminders to take their pills. Staying connected with family and friends on the internet is another support that can be provided with social media. There may also be support groups on these platforms that will allow the patient to feel a sense of community. Personal digital assistants are another tool that can be customized for the patient. This would help the patient remember tasks that they have to do for the day. Occupational therapists may have varying protocols that they follow when treating a patient with schizophrenia. However, some of the most common steps to treating patients include the following. We always want to obtain an occupational profile on the client. This allows us to figure out what the client's strengths are and what barriers are getting in the way of their occupational performance. It also gives us insight as to what the patient values and has motivation to engage in. Next is building rapport with the client. This is so important when working with these patients, especially because they tend to not trust a lot of people. Developing a trusting relationship with the client will help to improve outcomes. To aid in doing so, we can collaborate with the client to set goals for themselves. It's important that the client is able to contribute to making some of his or her goals so that they are more motivated to achieve them. As a therapist, we can help identify what is realistic for them and stepping stones that will help them reach their long-term goals. After goals are set, we will work to engage them in meaningful occupations. This may look to include a number of occupations based on what is important to the client. However, it is common to work on ADLs, IADLs, work, and social participation. We will go more into these occupations in the following slide. During engagement in occupation, we will also work on behavior modification strategies and improving the client's self-concept. Additionally, we can look at where an occupational breakdown is occurring and introduce adaptations and coping strategies for the client. As mentioned before, some of the common occupations that OTs will work on with these clients are ADLs, IADLs, work, and social participation. We can help the patient develop a schedule for showering and personal hygiene for them to follow every day. This will help them get into a good routine and improve their self-concept. We can also work with them on their health management. This could look like coming up with a schedule for taking their medication, engaging in an exercise routine, and also taking care of their mental health with activities such as mindfulness. Home management and shopping are other activities that fall under IADL occupations. Similarly, we can help come up with a set routine for cleaning up around the house and plans for when they are going to the grocery store. We can also implement coping strategies for them to have for when they are going out to the store. Empowering the client to engage in work is another thing we can help with, whether it be filling out job applications, interviewing strategies, or working on attention and concentration techniques for improved job performance. Finally, we can work on social skills with the client so that they can better engage with those around them. This includes being able to read social cues coming in, processing the information, and appropriately responding. In addition to these things, working on emotional processing and problem-solving skills are also areas that will help the client be more successful in their social interactions.
Current and relevant evidence. In a study from 2013, researchers Faruzanda and Parvin investigated the effects of occupational therapy on the symptoms of patients with schizophrenia. Patients with schizophrenia were randomly divided into the intervention and usual treatment group. Patients in the OT group were assigned to receive 6 months of treatment, 6 days a week, while receiving routine medications such as risperidone and piperidine. The intervention group was led by 2 occupational therapists. The intervention schedule was comprised of 7 parts. 1. Engage the client, establish the client's preferences on how to work together, and record the client's history, interests, and concerns regarding occupations. 2. Assess the client's competency in performing daily roles, routines, and occupations. 3. Identify the client's strengths and barriers that impact occupational performance. 4. Collaboratively set and prioritize goals concerning occupation and plan an individualized program of therapeutic activities. 5. Engage the client in planned activities, teach specific skills such as arts and crafts, and encourage the client to initiate actions, use support, encourage the client to participate in group work or work alongside the therapist, and develop routines and balance of activities. 6. Review with the client the meaning and impact of the client's chosen activities, encouraging the client to develop strategies that use occupations to improve well-being and alleviate psychotic symptoms. 7. Collaboratively continue assessing, reviewing outcomes, updating goals, and modifying actions to help the client achieve desired occupations. After the OT intervention, the OT group showed clinically significant improvement in positive and negative symptoms and in negative subscales such as avolition, apathy, social isolation, and anhedonia. In a study from 2011, Tatsumi and colleagues examined the effect of occupational therapy on interpersonal relationships and negative symptoms of hospitalized chronic schizophrenia patients with severe negative symptoms. The objectives of the study were to determine whether OT helps the patient to 1. Build a relationship with the therapist as measured by the patient's seating preference, and 2. Decrease the negative symptoms of schizophrenia as measured by the Scale for Assessment of Negative Symptoms. Before the intervention, patients were interviewed by the occupational therapist and asked to place a chair towards the therapist. Patients were then randomly divided into an OT group and a control group. Patients in the OT group participated in cooking activities once a week for 15 weeks. During cooking activities, therapists encouraged patients to participate in activities, set cooking goals, and follow step-by-step instructions. After the intervention, patients in the OT group were interviewed by the occupational therapist again. The distance of the seating location from the therapist significantly decreased, and the angle of the seating location significantly moved toward the therapist. Total scores on the Scale for Assessment of Negative Symptoms significantly decreased, showing that occupational therapy might improve negative symptoms in patients with schizophrenia. A study by Ramakrishnan in 2014 illustrated the experience of a 42-year-old male with schizophrenia with clinical features of a highly irritable mood, restlessness, hallucinations, fearfulness, sleep disturbance, poor self-care, and poor socio-occupational functioning. The occupational therapist's long-term goals for the patient were to improve social interaction, improve self-concept, and improve occupation by motivating him utilizing a behavior modification intervention in the model of human occupation. The therapist initially focused on management of skills while offering him activities to participate in. As time progressed, the patient gradually began to participate in activities with the therapist's encouragement and support. Once the therapist built rapport with the patient, MOHO was utilized to motivate the patient to perform simple tasks, and behavioral therapy was utilized to change inappropriate behavior. The therapist also taught the patient deep breathing exercises to help reduce hallucinations. In addition, the therapist used a soft tone when working with the patient. After OT intervention, the client's social behavior improved, he showed increased independence in activities of daily living, and his highly irritable mood, restlessness, hallucinations, fearfulness, and sleep disturbance all improved.
To complete today's learning activity, you will need a blank sheet of paper and a writing utensil. Directions will be provided on the following slides. To begin, please read the case study presented to you on the slide. Because creative activities are often used as an intervention for mental illness, we thought drawing a river model to interpret Jane's case would be a great learning activity. Before you get started, please read the slide for a refresher on the Kawa River model components. Then, draw the river model and label components according to Jane's case. Pause this slide while you complete the activity and move on to the next slide when you have finished. You will now check your answers based off of findings from a study published in the American Journal of Occupational Therapy by Huang and colleagues in 2018. The purpose of the study was to gain a better understanding for community engagement and restriction experienced by individuals with schizophrenia. Researchers asked participants to complete a photo voice project to reflect life within their community. The group discussions were transcribed and themed for each component of the Kawa River model. These results are what you will compare your answers to. So for the driftwood, there were 4 main themes: desire for relationship, the perspective of appreciation, responsibility, and private activities. For Jane, this includes the responsibilities she has as a student, employee, roommate, and family member, and her desire for positive relationships in both her personal and professional life. For the rocks, there were 5 main themes: symptoms of the disorder, financial resources, capabilities, interpersonal relationships, and lack of meaning in life. For Jane, this includes the hallucinations and delusions she's experiencing. It also includes her affect, her relationships with her roommates, and the way she feels about potentially failing her semester. Lastly, the river wall had 7 main themes: family, pets, religion, electronic communication, friends, nature, and medical interventions. For Jane, this includes her family and her enjoyment of the outdoors. Please pause the slide here and take a minute to compare your answers to the finding in the article and how it can apply to Jane. Thank you for completing the activity. If you want to read the article that was discussed, it's listed on the reference page, or you can access it by the link on the slide.
Here are our questions. Where do you feel that the boundaries lies between the role of an occupational therapist and a psychologist in a mental health setting? What are some therapeutic techniques you could use when interviewing an individual with schizophrenia? For this condition, what models or frame of references do you think could be useful for guiding practice besides the Kaba? What do you think are the main differences in occupational engagement when comparing premorbid functioning to the prodromal phase? Thank you so much for watching. Here are our references.